Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 73, that is the acid base balance. In this lecture we will cover the acidosis, that is the metabolic acidosis and respiratory acidosis, hemorrhage, hemostasis and congenital abnormalities of hemorrhagic condition, that is the hemophilia A and B, Von-Willebrand's disease. All points are covered in this lecture. So start with me. Acid base balance. In health, the pH of the body fluid is normally maintained within the narrow limits in spite of the large load of acid produced endogenously as a byproduct of the body metabolism. There are also important buffers in the body fluids which are mainly weak acids and bases. Kidneys are also important agents in the regulation of the composition of the body fluids. The reaction of the blood lies within the range of the pH of 7.36 to 7.44. Dear students, here is the image on your screen you are watching is showing the acid base balance, the importance of the renal system in the maintaining the acid base balance. The body phase is neutral, acidic and the basic is showing in this image. Now we start with the acidosis, metabolic acidosis. This is a condition in which there is a gain or retention of fixed acids or loss of the base, mainly bicarbonates. The causes are: first, gain of fixed acids may occur in diabetic acidosis, lactic acidosis, azotaemia, retention of the metabolites in renal insufficiency, rapid increase of the lactic and pyruvic acids by anaerobic tissues metabolism due to shock or cardiac arrest, or due to the rapid transfusion of the bank blood which has been preserved with acid citrate dextrose. The bank blood preserved with the citric acid. Second cause of the metabolic acidosis is the loss of the bases may occur in continuous diarrhea, that is the ulcerative colitis, small bowel fistula or prolonged intestinal aspiration. Now the clinical features: the initial compensation of the metabolic acidosis is pulmonary with an increase in the rate and depth of the breathing which depresses the arterial PCO2. Rapid, deep and noisy respiration is often called air hunger. The respiratory rate may rise to as fast as 50 per minute. Hyperapnea is due to the stimulation of the respiratory center by the lower pH of the blood. Overbreathing eliminates carbonic acid in the form of the carbon dioxide. Kidney also try to combat the acidosis by the sodium conservation, which helps to raise the pH. The urine becomes strongly acid. The pulse rate and the blood pressure may also be raised. Treatment: in case causes number 1, solution of the sodium bicarbonate should be infused. Frequent measurement of the electrolytes and blood pH are the best guide to therapy to estimate the amount of the alkali needed. And the second cause is the administration of the ringer lactate solution along with the sodium bicarbonate infusion easily cure the patient. Now second entity is the respiratory acidosis. This is less common than the metabolic type and is normally caused by the interference with the gaseous exchange in the lungs, leading to retention of carbon dioxide. In one word, inadequate ventilation is the cause of the respiratory acidosis. The causes are: anesthetized patient with too much relaxant may be unable to start proper ventilation for quite a long time. Second cause is the certain lung disorder, that is the empyema, bronchopneumonia, chronic bronchitis and pulmonary edema, etc. Third cause is the crushing or other injuries to the chest. Next is the peritonitis. Next is the respiratory centers may be depressed by the brain injury or by the poisoning with alcohol barbiturates, drugs or morphine and airway obstructions. Now the clinical features: this depends on the cause and degree to which the compensation is effective. During anesthesia, there may be slow rise of systolic or diastolic blood pressure. In most cases, respiration is abnormal, restless, hypertension and tachycardia are signs which indicate inadequate ventilation. Now the treatment: management of the respiratory acidosis involves immediate treatment of the pulmonary defect. Endotracheal intubation and the mechanical ventilation are sometimes necessary to achieve this goal. Encouragement of deep breathing, coughing and using humidified air to prevent insufficiency of the secretions may be required. Above all, over sedation and overuse of the muscle relaxation should be avoided. Now the alkalosis. First is the metabolic alkalosis. In this condition, both pH and plasma bicarbonate concentration are elevated. Metabolic alkalosis results from loss of the fixed acids or gain of base bicarbonate. Metabolic alkalosis in turn causes excessive urinary potassium loss in the exchange for sodium, which further accentuates alkalosis, so a state of the hypokalemic metabolic alkalosis results. Now the causes for the metabolic alkalosis are excessive ingestion of the absorbable alkali, which is not uncommon in patients who take various antacids or indigestion remedies without medical supervision. Second cause for the metabolic alkalosis are the persistent vomiting in pyloric obstruction. Continuous gastric aspiration is quite common cause. The loss of the chloride causes accelerates loss of sodium and bicarbonate in the urine and partial compensation of alkalosis. The alkalosis itself causes increased renal excretion of potassium. Third cause is the prolonged administration of the cortisone. ACTH or deoxycorticosterone acetate may cause alkalosis with potassium deficiency. Now the clinical features of the metabolic alkalosis are onset of the respiration, which is the first shallow and then increase in depth until the exertion is normal. Tetany may occur in severe alkalosis, which is the cause of an increase in irritability of the skeletal muscles. Now the treatment of the metabolic alkalosis are, the main treatment is to remove the cause. Next consideration is to maintain an adequate volume of blood. Next consideration is to bring down alkalosis by giving ammonium chloride. It must be remembered that the potassium depletion goes hand in hand with metabolic alkalosis. So intravenous infusion of the solution of potassium chloride is also necessary. Now the next point is the respiratory alkalosis. Respiratory alkalosis is caused by the hyperventilation, which reduces the tension of the carbon dioxide in the alveolar air and hence in the plasma. So extracellular carbonic acid concentration falls and the pH rises. The main causes in the surgical practices are during anesthesia, when the excessive manual pulmonary ventilation is executed with the use of the muscle relaxant. Second is it may also occur due to the apprehension, pain and or central nervous system injury. Due to the hysteria, next cause is the high fever and next is the salicylate or carbon monoxide poisoning. Arterial PCO2 should not be allowed to fall below the 30 mm of Hg. Now the clinical features of this condition are, the patient becomes pallor and the blood pressure falls, acidosis. In both acidosis and alkalosis of the respiratory origin, there is some risk of the respiratory arrest. The disturbance is severe. This is much more common in alkalosis than in the acidosis. Now the treatment, frequent blood gases estimation and appropriate correction of the ventilatory pattern are required when mechanical respirators are used. Adequate care should be taken to correct the potassium deficit, which is a common accompaniment of this condition. If alkalotic respiratory arrest occurs, it should be immediately corrected by the insufficiency by carbon dioxide. Now the next point of this lecture is the hemorrhage. According to the source of the hemorrhage can be classified into two ways. First is the external and second is the internal. First, the external hemorrhage is one that is the revealed outside or seen externally. Second is the internal hemorrhage is one that is not seen from the outside or it is concealed hemorrhage. This type of the hemorrhage is seen in the bleeding, peptic ulcer, ruptured ectopic gestation, fracture of major bones, rupture of spleen or liver. Sometimes concealed hemorrhage may be revealed or external hemorrhage. Now the next point is the hemorrhage may be the arterial, venous or capillary. First is the arterial hemorrhage. When hemorrhage occurs from an artery, it is called arterial hemorrhage. Such hemorrhage is recognized by the bright red color and it is ejected in spurts with each systole of the heart. Second is the venous hemorrhage, is one which comes from the vein. It is characterized by a dark red color and it outflows out steadily instead of spurts. This is the quite characteristic of the venous hemorrhage. Next is the capillary hemorrhage, is one in which the hemorrhage comes from the capillaries. In such hemorrhage, blood is bright red and oozes rather than flows out. According to the time of appearance, hemorrhage can be classified into primary hemorrhage, reactionary hemorrhage and secondary hemorrhage. First, primary hemorrhage is one in which the occurs at the time of the injury or operation. Second is the reactionary hemorrhage, is one in which the occurs within 24 hours of injury or operation. In majority of cases, reactionary hemorrhage occurs within 4 to 6 hours. Such hemorrhage plays due to the dislodgement of the blood clots or slipping of the ligatures. This mostly occurs due to the rise of the blood pressure when the patient is recovering from the anesthesia or shock. Such bleeding may also occur due to the restlessness, coughing or vomiting, which raises the venous pressure. And third is the secondary hemorrhage. This occurs usually after 7 to 14 days of injury or operation. This is usually due to the infection and slipping of part of the arterial wall. Now the next point is the clinical features of hemorrhage. Increased pulse rate, low blood pressure, increasing pallor, restlessness and deep signing of respiration, that is the air hunger, cold and clammy extremities, empty veins, Pulse rate and blood pressure should be measured 1/4 and a half hourly. Interval when the patient is losing blood during his stay in the emergency department, often the blood pressure is maintained at normal level by the peripheral vasoconstriction due to the adrenergic release. When the patient is still bleeding, pulse rate is a better indicator of hemorrhage than blood pressure. Usually with hemorrhage, the pulse rate is increased when the blood loss has been excessive. The blood becomes of low volume, which is classically known as the thread pulse. Measuring of urine output is obligatory in patient who is losing blood. Urine output becomes low in the patient suffering from hemorrhage and the shock. The measurement of the blood loss, it is often important to measure how much the patient has lost blood. The best method of detecting the blood loss is by weighing the swabs. The other method are measurement of the swelling in case of the bleeding from fractures and measurement of the blood clot in hemorrhage. First is the weighing of swab by the blood. This of course is the best method of measuring blood loss during the operation. The swabs are weighted before they are used and they are weighted again after they are soaked with the blood. This measurement is a 1 gram is equal to 1 ml of blood loss. And second is the measurement of the swelling in closed fractures. In case of moderate swelling is the closed fractures of the tibia, the blood loss is estimated about 1 to 1.5 liter. Third is the measurement of the blood clot. When the collected blood clot are kept in the spot and measured again a clenched fist of the patient, total blood clot of the size of the clenched fist is equal to the 500 ml of the blood. The clenched fist should be the patient. Now the blood volume determinations. Blood volume is equal to red cells volume plus plasma volumes. The hematocrit readings gives the ratio of the plasma to red cells. Hemoglobin level is often considered as a good indication of the hemorrhage, but it is practically not so. It is initial stage, the hemoglobin level remains normal. It is only lowered after a few hours of the hemodilution caused by the movement of the extracellular fluid into the vascular space due to the natural attempts to restore blood volume. The normal volume of the hemoglobin is about 12 to 16 gram per 100 ml. Measurement of CVP or central venous pressure is good method to detect loss of the blood volume in hemorrhage. Now the treatment of the hemorrhage, it consists of two parts. One is to stop the blood loss immediately and second is to restore the blood volume by blood transfusion, infusion of the crystallized solutions and infusion of the plasma and plasma substitutes. First, the blood loss is stopped by the mainly three methods. First is the rest, second is the pressure and packing from the outside, and third is the bioperative methods. First is the rest. Absolutely, the rest is vital so far as the treatment of the hemorrhage is concerned. If the patient becomes restless due to the pain, hemorrhage will be more. And second is the pressure and packing from the outside. This is mainly a first aid treatment. Sterile piece of the gauze and bandage may be used as a pressure bandage to reduce bleeding from the external wound. In the accident cases, we will see this usually. Use of the tourniquet to stop hemorrhage has been obsolete. Now the method of the application, the limb is elevated and a smudge bandage is applied spirally to elevate the limb from towards the thigh. Removal of the tourniquet, the time of the application of the tourniquet must be written on the blackboard in the operation theatre. Tourniquet should not be used for more than 1.5 hours. Always remember this. Now the third cause by operative methods. During operation, hemorrhage is usually stopped by the artery forceps that the hemostats and the clips applied to the bleeding vessels. Now the bleeding vessel is either ligated with catgut or silk according to the size of the vessels. Smaller vessels can be colligated with diathermy. In case of the big vessels like renal artery and vein transfixation, suture may be used with silk. Stop such huge bleedings. This type of material provides a network upon which the fibrin and platelets are deposited to stop bleeding. Such bleeding can also be stopped by the gauze soaked in adrenaline solution, that is the 1:1000. Now the chronic hemorrhage, bleeding from the hemorrhoids, carcinoma of cecum and the peptic ulcers are examples of the chronic hemorrhage. The patient becomes anemic. Natural restoration of blood volume after hemorrhage. As soon as the hemorrhage or bleeding takes place, nature almost immediately starts to replenish the blood volume. This is required to maintain the blood flow to the vital organs. First of all, interstitial fluid is absorbed into the vascular space. This causes hemodilution. Plasma proteins are replaced by the liver in the short time. However, red cells recovery takes more time, about 5 to 6 weeks. Iron absorption should be insufficient to maintain this period. As soon as the hemorrhage takes place, every effort should be made to restore the blood volume by blood transfusion. Only when blood is not available for the time being, plasma or plasma substitutes may be used. Now the next point is hemostasis. Natural attempts of the hemostasis or stoppage of bleeding starts immediately at the site of the bleeding. The first step in achieving the hemostasis is due to the local release of the humoral agents known as the thromboxane. These agents is a powerful constrictor of the smooth muscles and promote the aggregation of the platelets. This causes constriction of the small arteries and the spontaneous sealing off. It is probably released by the platelets at the site of the disruption of the endothelial surfaces. Platelets are one of the essential components of the hemostasis. A contractile protein in platelets, which is known as the thrombostatin, allows the platelets plug to the contract, thus the reinforces the contraction of the vessels. Platelet factor 3, a thrombogenic phospholipids, is also released locally, which promotes coagulation. The next mechanism in hemostasis is the formation of a fibrin clot, the process of which is known as a coagulation. Coagulation sequence leads to the formation of the thrombin, which splits fibrinogen to form insoluble fibrin, which is acted upon by a factor 8 to form a tough clot. Another important aspect of the coagulation is the fibrinolytic process, which prevents formation of the intravascular fibrin, formation of such fibrin and excess fibrin in areas where it is not necessary will digestous. Now, the next point is the congenital abnormalities of the hemostasis. The most common congenital abnormality of hemostasis is hemophilia. Christmas disease is the next. Hemophilia, that is the hemophilia A, it is a sex-linked inherited disorders or is carried by a recessive gene, so that it manifests only in males and asymptomatically transmitted through the female's carrier. It involves an almost total lack of factor 8 activity. The level of the coagulation factor 8 in the blood may be less than 1% of normal individuals. Clinical features: bleeding after the slight trauma is the main problem. Sometimes the hematuria is noticed. Death in hemophilias usually results from the bleeding into the central nervous system. Now, the treatment of the hemophilia A is the cryptoprecipitates is a rich source of the factor 8. Periodic infusions of this cryoprecipitate will increase the level of the factors 8. Monitoring of the factors 8 level should be performed after each infusion. If any operation has to contemplate, this should be performed only after the raising the level of factor 8 to almost normal level. Alternative form of the therapy includes fresh blood or fresh frozen plasma. Next is in the congenital abnormality of the hemostasis is the Christmas disease, that is the hemophilia B. This is the second most common congenital disorder of the coagulation. In this condition, there is a congenital deficiency of the factor 9. Now, the treatment is transfusion of fresh frozen plasma. There is no definite substitute of the factor 9 and hence the treatment is less effective. Cryoprecipitate may be used in this condition also. And the final disease of the congenital abnormality of hemostasis is the Von-Willebrand's disease. This is the third most common inherited disorders of the coagulation. Clinical manifestations vary in severity, but the bleeding tends to be more from the mucous membrane than from the musculoskeletal system. In this peculiar condition, there are low plasma levels of the factor 8 complement and factor 8 related antigen. There is also some platelets abnormalities. All these combine to give rise to the bizarre episodic bleeding manifestations. Dear students, here is the end of our surgery lecture number 73, that is the acid-base balance and hemorrhage and hemostasis. To know the more details, you can refer the textbooks regarding this point. Thank you, students.